All right, so I think we'll get started. Hi, everyone. My name is Lisa Anatoni. I'm a physician in dermatology in Montreal. I'll be the host for this event. Bonjour tout le monde, je m'appelle Lisa Anatoni. Je suis médecin à Montréal. Puis c'est moi qui va gérer l'événement aujourd'hui. So thank you so much for being here for the launch of the Canadian COVID Society. We have our board of directors and invited guests that will say a few words, and there'll be an opportunity, if necessary, to ask questions at the end. Donc, merci beaucoup d'être venu pour le lancement de la Société canadienne de la COVID. On a notre conseil d'administration qui va vous parler un petit peu de cette nouvelle entreprise, puis il y aura un moment à la fin où vous pourriez demander vos questions au besoin. So I will ask at this time Chris Houston to come up to give a land acknowledgement.
Thank you, Dr. Lisa. My name is Chris Houston, and I am a member of the board of directors of the Canadian COVID Society. The well-traveled amongst you will notice the Scottish accent. I am a proud immigrant to Canada and therefore also a settler on this land. I am in Bancroft, Ontario, on the unceded territory of the Algonquin Anishinaabe. In this digital meeting, I imagine everyone is in different parts of Turtle Island. I wish to express my personal gratitude and on behalf of the organization, our collective gratitude, the generations of Indigenous peoples who have cared for the land for countless generations. Personally, the land sustains me. It's good for my mental health, and I'm sincerely grateful to those that have cared for that land before I arrived here, and to the Indigenous people who have cared for the land and who share it with us. Thank you.
Thank you so much for that, Chris. I saw that the recording was just started, so I'll just restate that we're here today for the launch of the Canadian COVID Society. On est ici aujourd'hui pour le lancement de la Société canadienne de la COVID. So now I'll put up some slides and introduce you to the board of directors of this new foundation. Je vais prendre quelques moments pour vous introduire au conseil d'administration. So first up, we have Dr. Joe Vipond, who is an emergency doctor in Calgary, Alberta, and a past president of multiple associations, past president and co-founder of multiple associations, such as the Canadian Association for Physicians for the Environment. On a Dr. Joe Vipond, qui est un médecin urgentologue en Calgary et professeur à l'université, professeur adjoint à l'université Cumming de Calgary, Université de Calgary. On a Dr. Kashif Pirzada. We have Dr. Kashif Pirzada, sorry, thinking in two languages. Dr. Kashif Pirzada, who's an emergency physician based in Toronto. He's also a clinical assistant professor at McMaster University. On a Dr. Kashif Pirzada, qui est un médecin urgentologue à Toronto, qui est professeur adjoint à McMaster. Then we have Cheryl White, who unfortunately could not be here today, but who is an engineer, cancer survivor, and patient advocate. On a Cheryl White qui n'est pas avec nous aujourd'hui, mais qui est un ingénieur, un survivant du cancer et qui fait beaucoup de travail dans l'intérêt des patients. We have Chris Houston, who's done a lot of international humanitarian work with Doctors Without Borders, the Canadian Red Cross, the World Health Organization. On a Monsieur Chris Houston, qui a fait beaucoup de travail humanitaire pour Médecins Sans Frontières, la Croix-Rouge et l'Organisation mondiale de la santé. We have Nancy Delagrave, who is a college physics professor and who has been involved in air quality and safety initiatives for over 10 years. On a Nancy Delagrave, qui est un professeur de physique au niveau collégial et qui fait beaucoup de travail au niveau de la qualité de l'air et de la santé et sécurité au travail depuis plus que 10 ans. And so now I will introduce the mission of this new foundation. And I think there's a slide to that effect as well. All right, so the mission is to protect the health and safety of people in Canada against the harms of COVID and long COVID through education, engaging and empowering the public and organizations with scientific knowledge. Next slide. La mission. et d'informer la population sur les conséquences des infections COVID pour la santé, de plaider pour la mise en place de moyens basés sur la science pour réduire la transmission du virus et de défendre et soutenir les personnes atteintes de COVID. And so now I'll ask Dr. Kashif Prasada to come up and speak for a few moments.
Thank you, Dr. Lisa, for the opportunity to speak. Bonjour and bienvenue to our meeting today. Why are we starting the society? Basically, since 2020, COVID is a fact of life. It is one of the leading causes of death. And we have foundations for heart disease, we have foundations for cancer, but we need a group dedicated to fighting COVID-19. Now, this is reflected in stats. In the last year where we have data, 2022, COVID-19 is the third leading cause of death. That number fluctuates, but considering it can contribute to cardiac and cancer deaths, it will continue to be a threat to all Canadians for some time to come. And it is overwhelming our health system. This is data from Ontario showing increases in hospital admissions in children in the last year and in the year before. And in the elderly cohort, in the 65 and above, just in the last year. These are fully vaccinated people still suffering from the acute effects of COVID and requiring admission to hospital. And you can see from federal data that hospital admissions have never really stopped from COVID-19, even after the vaccination campaign. It still continues to be a stressor on our health system up to this present day. It is contributing to poor health and excess deaths. It causes immune system problems, and which are leading to a lot of strange things, such as a huge rise in group A strep, invasive group A strep, causing deaths in young and old alike. It is causing reactivation of older illnesses like shingles. Even this paper published yesterday from Japan and Korea shows increasing incidence of autoimmune diseases. This study from Tara Moriarty, who's based on the last excess death availability from StatsCan, shows amongst all age groups, there is an increase in excess mortality, up to 27% in the 0 to 44 age group. And this is data from Quebec, showing similar findings as well. And from the New York Times, showing during the holiday period, there were 2,000 deaths a week in the United States. So this is continuing to be a problem that is bedeviling our population. It's contributing to a drop in life expectancy across the country, which does not show any signs of slowing. Our goal with this society is to increase awareness campaigns nationwide to educate the public on the prevention of COVID, its spread, and the importance of ongoing vigilance. We want to build supportive networks. Right now, if I have a long COVID patient, I literally have nowhere to send them. There aren't organized specialists. There isn't organized treatment for them. Also, policy advocacy. We need to break through the denialism that is keeping us from acting on this threat. It's not what it was in 2020, but it is still a problem, and we need to evolve the language and the practices of trying to avoid this problem.
All right, thank you so much, Dr. Prasada. Maintenant, j'inviterai Madame Nathalie Delagrave pour dire quelques mots.
Bonjour tout le monde, je suis Nancy Delagrave. I will speak in French since I am the only francophone member of the board. Présentement, nous sommes dans une phase différente de la COVID. Nous ne sommes plus dans une phase d'urgence, mais nous sommes dans une phase où les maladies chroniques sont de plus en plus présentes. Je vous demande de regarder autour de vous. Vous connaissez peut-être des jeunes familles où c'est rare qu'il y ait tous les membres de la famille qui sont en santé. Vous connaissez peut-être une personne âgée qui a attrapé la COVID et juste après, elle fait une chute, elles ont plus de problèmes cognitifs. Moi, c'est ce que j'entends partout autour de moi. Donc, comme la Société canadienne du cancer, qui avait été fondée parce que les médecins trouvaient que quand les gens arrivaient pour les consulter, il y avait déjà beaucoup trop de dommages qui avaient été créés. Nous, on veut être là avant la vague et s'intéresser aux conséquences à long terme de la COVID sur la main-d'œuvre, mais aussi sur notre santé en général. Au Québec, en 2022, l'Institut statistique du Québec a dit que l'espérance de vie avait baissé de 9 mois. Il y a un média qui en a parlé, c'est Pivot, et il disait que c'était quelque chose d'historique. je regarde activement ce qui se passe et les données de 2023 montrent que ça ne sera guère mieux. Il faut que vous pensiez que, dans le fond, toute la société canadienne, on a toujours voulu augmenter notre espérance de vie. C'était des progrès sociaux. Et là, on est en train de renverser les progrès que l'on avait faits. Donc, je demande qu'on applique des solutions simples. C'est ce que nous demandons tous ici. Par exemple, la ventilation qui réduit plus de 80% des infections lorsqu'elles sont bien appliquées et qui travaille aussi pour la rougeole. Et donc, c'est ça. Back to you, Lisa.
Merci beaucoup. Thank you so much. Next, I'll ask Chris Houston to come up and join us.
Thank you again, Dr. Lisa. I'm Chris Houston. I'm a writer, consultant. I'm faculty at the University of Toronto's Global Health Education Initiative. I have charitable governance experience at Médecins Sans Frontières and the Canadian Peace Museum. I serve on my local municipal government safety and wellness committee. I worked at Canadian Red Cross, Médecins Sans Frontières, the World Health Organization, Grand Challenges Canada, and the Heart and Stroke Foundation of Canada, as well as in pediatric healthcare in Ontario. I'm proud to be part of this team. I think the work is essential. The prevalence of misinformation and confusion concerns me. I'm keen to ensure that we do this work with the prioritization of medical ethics and the inclusion of people affected by COVID. To those that have donated to make this possible, I say thank you. Cheryl White is a professional engineer and a cancer survivor. Cheryl was receiving cancer care at the start of the COVID pandemic. This experience has informed her deep passion for preventing COVID spread in healthcare, as well as in educational establishments, workplaces, and community settings. Cheryl brings deep passion for this work and a track record of cross-functional team leadership. She also brings experience of working in deeply complex problems, and she apologizes that she is not here to join us for this lunch event. Thank you.
Thank you so much. I'll now ask Dr. Joel Vipond to come up and say a few words.
Bonjour tout le monde, c'est excellent d'être ici. I'm going to speak predominantly in English, but when we get into the question and answer phase, I'm happy to speak in either language parce que je suis bilingue. Je viens de Calgary, Alberta. I'm from Calgary, Alberta, and it's been a rather bizarre journey to be an advocate through COVID, right? Like we've had a lot of grassroots efforts that have gone into, in a lot of ways, countering some of the public health narratives about COVID not being airborne, the lack of mention of long COVID that continues to this day. And there's been some just incredible voices across the country. So why don't we just continue with all those great volunteers? Well, guess what? Volunteers have a finite amount of energy. They have a finite amount of time, and it's been 4 years. So for multiple periods during this pandemic, we've said we should start a national organization. But there's always been this sense, okay, well, we're in the last wave, so why would we bother starting an organization at the very end of a pandemic? Except it's never the last wave. There's always been another one. By my count, we're at 10. And so I hope this is the last wave, but I think we have to plan as if it's not. So what a formal organization allows is for us to raise money and hire staff. And instead of relying on impassioned, intelligent volunteers, we're going to try and transition to relying on impassioned, intelligent staff. And that's why this organization is going to exist. And, there's so much work that we need to do, including advocating for better air quality in public spaces, including our schools where, 40 some kids are elbow to elbow for 8 hours a day, for continuing mask use in hospital and the correct mask, respirator masks that are designed to protect against airborne illness, and to continue the efforts to share with people what long COVID is, why it's important, how to prevent it, and finally to talk about airborne transmission of COVID. To this point, it's been minimized, and you can imagine how hard it is to protect people against chlamydia if you never mention the word sex. Well, chlamydia is a sexually transmitted disease. COVID's an airborne transmitted virus. We need to talk about the elephant in the room, which is airborne transmission, and that'll speak to our logo. I'm quite thrilled by our logo. As you can probably see, it's a dandelion, which evokes the shape of the COVID virus. And with the dandelion seeds floating off into the distance, evokes the airborne nature of COVID. So every time you look at our logo, I hope you think, oh, COVID is airborne. I need to protect myself. Finally, I just want to put a call out to those people who may care about the mitigation of COVID at this time, that you can support us. You can support us predominantly at this point, at this juncture, through donations. We need to raise enough money to hire staff, and hopefully at some point we'll have a volunteer network where we can actually mobilize volunteers, and we'll be using all of your skills. So thanks for allowing me to be here and be a part of this crazy adventure. And I hope we can make change to bring change to the Canadian landscape on illness.
Thank you so much for that, Dr. Vipon. And finally, we have Dr. Jennifer Hume, who is not part of the board, but rather is somebody who's living with long COVID, who's here to speak to us about that experience.
Thank you, Lisa. Yeah, my name is Jennifer Hume. I'm an emergency and addictions physician here in Toronto, but I'm speaking to you today about my experience living with long COVID. Je suis médecin urgentologue ici à Toronto, mais je veux partager un peu mon expérience avec la COVID longue. Il faut noter qu'il y avait plusieurs patients francophones qui étaient supposés d'être ici aujourd'hui. Ils sont même trop malades pour vous parler directement. Ils ne peuvent pas être assis pour 5 minutes pour être ici. Et ça, c'est vraiment ce que je veux communiquer avec vous aujourd'hui, que la COVID longue est souvent invisible. Et beaucoup d'entre nous sont trop malades pour sortir de la maison. Beaucoup d'entre nous, on a perdu nos emplois, notre logement, nos amis et notre vie. Le dernier rapport de Statistique Canada a montré que 2 millions des Canadiens souffrent de la COVID longue. Le Forum économique mondial, le Financial Times, l'Économiste, ils sont tous préoccupés par la COVID longue et ses effets sur l'économie. L'année dernière, la COVID longue a empêché à 4 millions de personnes aux États-Unis de travailler. So today I really want to describe to you what this looks like, what disability and what this illness looks like by describing my own experience. This photo on the left is me 2 weeks before getting COVID, and I'm cross-country skiing, as I love to do. And on the right, this is me 6 months later in a clinical trial. Next slide. I got COVID in April of 2022 from my son, from kissing him goodnight through the banister. And I had a fairly uneventful run, just like most people. I had, I was quite sick, but with viral symptoms and some roving joint pain, which was a bit unusual. And I was sick for about 9 days, but I recovered quite nicely. I was able to walk, think, function, take care of myself. And I went back to work. On day 11, I was fatigued, but otherwise okay. I worked a few overnight shifts that weekend, and I tried to go for a run, and it was a complete disaster. I was training for a 10K, and I couldn't run at all. I was very short of breath, and I thought, oh, that's odd. But I completely recovered, I slowly walked home, and I thought I must just be deconditioned, and I'll take it slow. And then 21 days after testing positive for COVID, I woke up extremely ill with every long COVID symptom imaginable. Because I knew what this was, I was absolutely terrified. I became suddenly mostly bedbound with relentless fatigue, post-exertional malaise, memory loss, headaches, pulsatile tinnitus, which is a constant whooshing in your ear that doesn't stop. I had severe sensitivity to noise, to sound, so that I couldn't eat dinner with my family because I couldn't stand the scraping of the knives on plates. I couldn't remember my address. I was so severely cognitively impaired. And I also felt that I was going to pass out every time I stood up. And I later learned that was a post-viral condition called POTS, where there's not enough blood getting to the brain. I secretly dreamed of losing a limb, just something really concrete that someone could tell me what was wrong and try to help me. But instead, I was just kind of pale, but I looked fine while barely being able to walk. Next slide. Long COVID took over my life and encroached, every aspect of my identity as a mother, as an active person, a social person, as a physician, as a researcher. I went off work and onto disability, and I was still really desperate for answers and desperate to feel better. I tried every medication, every supplement, and some of them helped. I joined every clinical trial, and some of them helped. My sick body became a human laboratory. I wrote a piece for Healthy Debate from my bed as a way of communicating the experience of being, suddenly disabled by COVID while the rest of the world seemed to have moved on. In July, next slide, I suddenly lost hearing in one ear, and I developed a new form of tinnitus with this high-pitched screaming sound in my ear nonstop, and I lost hearing in one ear. I saw a specialist who confirmed sudden sensory neural hearing loss and who ordered an urgent MRI, which to this day I've never gotten a call about. I was sent home with advice to just rest and hope. Because I knew that hyperbaric was indicated for sudden sensory neural hearing loss, and because there was early evidence of benefit in long COVID, I pursued this myself. And it was amazing. I got my hearing back and tinnitus stopped within a number of sessions. I was so relieved. And after I finished those 20 sessions for hearing loss, I continued in the chamber paying out of pocket to an amount that would impoverish most people. Next slide. I'm back to work part-time now, and I'm really grateful for the good hours and the good days that I do have, which are more and more frequent. So many people ask me, what do I want the public to know about long COVID? And I think the first thing I really want to highlight is that, the tests are not normal. We're not ordering the right tests. We don't have a biomarker. So every study of long haulers shows unbelievable pathology, immune dysregulation, mitochondrial dysfunction, neuroinflammation, brain damage, vascular damage, gut damage, poor perfusion of the brain, poor perfusion of the lung. We just don't have a biomarker. We don't have a blood test yet that's like the single thing that will tell us you have long COVID. The second thing I want people to know is that there are currently 0 approved treatments by the FDA or Health Canada for long COVID. And the trials that are ongoing right now, only 12 of them are looking at pharmacological treatments. And so this means, for the 70 million people worldwide who are desperately sick, they continue to experiment on their own using HIV drugs, traveling across the world for plasmapheresis, and continue to be desperately sick and needing real treatment. And the third thing I want people to know is that the best way to prevent long COVID is by avoiding getting COVID, which is easier said than done. Vaccination reduces your risk, but everyone remains at risk of getting long COVID. I can tell you, I personally, use masks in crowded areas with poor ventilation. I use nasal sprays. I use CPC mouthwash. I use a personal HEPA filter. I use an AirNet to know, whether there's good air exchange. And I'm working with the Cochrane Center on evidence for all of these things. But people need to know what the epidemiology, what's going on in their communities in terms of the burden of COVID. And we will all benefit from the public health interventions that will give us clean indoor air in our public spaces. Merci. I'm very happy to answer your questions afterwards.
Thank you so much for sharing that story with us. So I just want to take a minute to repeat in English what Jennifer said in the beginning, which is that originally we had 3 long COVID sufferers that were supposed to be here to speak with us, and 2 of the 3 were too sick to join us, too sick to even be able to sit up and participate for a few minutes in a press conference like this one, which I think really speaks to the magnitude of the way this illness changes your life. So that concludes our official sort of presentations and introductions. If there are any questions, I will try to monitor the chats on YouTube and on here, or if you're a journalist, you can ask your question directly. I see that there's one. Nicole Ireland. All right, you should be allowed to speak.
We're going to bring all the journalists up onto the stage. We can ask questions.
Sorry about that. Can you hear me okay? Yes, we can hear you. Sorry about that. For Dr. Hume, how do you think that having this society will help people who are dealing with long COVID, as opposed to what do you hope? I mean, because you've talked about sort of this patchwork of clinical trials. What do you expect from this society?
Yeah, I think right now, long haulers really are seeking an organization to consolidate advocacy for primary and secondary prevention of long COVID. So what does that mean? That means, like, how do we not get COVID in the first place? And then what do we do when we do get COVID? Because that's a big question. There are early trials showing benefit from metformin, for example. But how can we prevent long COVID if we don't know if we have COVID or not? We need accurate rapid tests. We need access to information on the community burden from not just wastewater, but other sources to know, what's our pre and post-test probability of having COVID in the first place, getting the rapid test, getting a diagnosis, and being able to treat. Currently there is a clinical trial looking at whether Paxlovid reduces the incidence of long COVID. But these are the types of things that people with long COVID want to see, and with a consolidated and strong public health effort and public health communication around these issues. So I think that's what I'm personally hoping to see.
Thank you very much for that. And could I ask a follow-up to Dr. Vipond?
Absolutely.
Hello, thank you. Hi, Dr. Vipond. I just wanted to ask you, in terms of funding, so this is a nonprofit, you did mention some donations. I'm wondering, is there any federal government funding? Have there been any conversations with PHAC, for instance?
No, this is it. This is our launch. So we're just starting off on our adventures. To start off, we're not a charity. We're a nonprofit, and that's just part of the structure of the way the taxation system works here. In order to become a charity, you have to first be a nonprofit, register with either the federal government or a provincial government. We're federally registered. And then you have to apply for charitable status. We've actually started on that process of applying for charitable status. And so hopefully that can take anywhere from 3 months to 2 years. So hopefully it'll be on the shorter side of things. In the meantime, we're focusing our efforts on grassroots fundraising, and we're hoping to get donations from people, small $15, $20 donations from people who can help us to get enough money to hire staff. And to be clear, we've already had the conversation as to how much money we need in the bank in order to do that. You kind of need a year's salary. And if you can imagine what that would mean to hire an executive director, it's not small change. As a nonprofit, there may be some grants that we can apply to, but we need to go through that process. All of our efforts so far have been bylaw writing, choosing a logo, focusing on this website. I mean, this launch a website so that we're a formal organization, and now we can go through the process of actually hiring staff, hopefully, if we raise that money. I hope that answers your question.
It does. Thank you. And I was just wondering if you mentioned the need to know the epidemiology, the need to know numbers and what's happening at any given time, whether it's wastewater, et cetera. So is that a void that this society will fill? Will this be a place where people can go to get that epidemiological information?
We don't have the ability to get more information than what the government has. We're not going to be going out there and collecting this information. Hopefully, if we get to the site where place where people feel it's necessary, our website can provide the collated information that's collected by others. But we're a long ways away from that at this point.
Thank you.
All right, thank you. I'll now invite Melanie MH.
Hi. Sorry, I forgot my camera wasn't on. Thanks for the information. I just wanted to know, I know that you seem to be, there's quite a few things that you seem to be focusing on, as much as you want to, a lot of sense de la sensibilisation, sorry, I'm thinking in French, and things like that. How are you going to be working with public health agencies? Because I mean, generally public health agencies are supposed to give out information about viruses, about illnesses and things like that. So what's the work that you'll be doing with them, if any?
If I can start with that, I'm sure somebody else wants to answer as well. But I feel in some ways we're filling a gap where public health has left open. I'm from the province of Alberta. Our public health chief medical officer of health has had one press conference since June of 2022, if I'm not mistaken. So it's been well over a year and a half. That one conference was about an E. coli outbreak at a daycare. There's basically no mention of COVID. There's no mention of long COVID. It's really fallen off the radar for a lot of public health at this point. And so I would love for them to take over, make us useless, take over the job, please. I beg of you. But until such time as they do that, I think we'll be filling that gap.
I just wanted to add some comments, and I think part of the mission of this society is to make it possible for public health to push back. Like if you look at you take a public health course, it's half 1 foot is in politics, 1 foot is in medicine. But right now, the public doesn't want to think about this. Politicians don't want to think about this, and public health has to respond to that and doesn't think about this. So part of the goal of the society is to keep, this, killer of a huge number of Canadians, this disabler of a huge number of Canadians on the radar, so that it can't just be brushed aside, and it always is a factor in consideration, political and public health considerations.
Maybe
oh, sorry, go ahead.
Maybe I can add a few things. Most of us have been doing COVID advocacy for 4 years, and we have some contacts with public health. I recently spoke with people in public health this fall, and one thing we're hearing from the federal government is that since there has been so much politicization of COVID, what they need is actually citizen advocacy to do a counterpart and, scientific citizen COVID advocacy. Because even, what the federal is hearing, from the provincial side is highly political, and, the provinces have kind of stuck together. And, there's been requests of information things where we see that they all, talk together. So basically the way to, have an influence is to have citizens who speak, for the good, for the greater good of everybody.
En français, Nancy?
Oui, bien sûr. Donc, ce que j'allais dire, c'était que la plupart d'entre nous, ça fait très longtemps qu'on fait dans le fond, de la sensibilisation pour la COVID. On fait partie aussi de plusieurs organisations, dont des organisations d'hygiénistes du travail, des choses comme ça. Et on est en démarche avec la santé publique du Canada pour être connu et pour être invité à la table, aussi pour recevoir des subventions. Ce que l'on a entendu est que parce que la COVID, elle a été tellement politisée, pardon, ça a créé un rapport de force qui est difficile. Et donc, même le rapport fédéral et provinciaux était tendu parce que toutes les provinces ont eu la même ligne et ils partageaient ensemble l'information, dans le fond, électroniquement. Donc, nous, notre but, c'est de parler pour les citoyens, de la santé des citoyens. Donc, il n'y a rien de mieux que des gens qui sont des scientifiques, qui sont des médecins, qui prennent, dans le fond, le bien commun comme priorité, comme message.
Thank you, merci. There's a question that came in online from the stream. For those of us who are still doing everything to avoid COVID, will this society be involved in activism to protect us in public spaces, especially in essential services like public transit and medical settings?
I don't want to monopolize the answers, but maybe I'll just start. I'll just say in particular, the medical masking I think is very something very at heart for myself. Working in the emergency room, hearing the stories of people getting COVID in hospital. Sometimes they get COVID in hospital, they go home, and then they have to come back because they're so sick. And that's when I see them in the emergency room. The hospital spaces and long-term care spaces, in my mind, are special spaces that we should consider forever masking, at least until we get rid of this debilitating, deadly illness. It's a safety tool akin to wearing a construction helmet on a construction site. It's moderately uncomfortable and protects you. And not only protects you, but protects others around you. The people who come to hospitals are particularly vulnerable. They are our elderly. They are our immunocompromised. They are people with multiple medical problems. And we put all this effort into preventing other hospital-acquired illnesses like C. diff, the diarrheal disease, or tuberculosis, measles. We have all these protocols. But COVID is special because of its asymptomatic spread and its airborne nature. It kind of means you have to wear a mask all the time if you want to protect yourself and others. And that makes it different than some of these other illnesses. Also, the prevalence in society, right? Like, who knows where measles is going to be, but right now it's, 10, 15, 20 cases in Canada. There's a lot more COVID in Canada than there is measles. And because of those special factors, I personally believe that we should never lose masks in hospitals, and I hope that we take that on as an advocacy task. I'm just one member of a 5-person board, and I hope that we'll have robust discussions going forward.
Thank you for that. Now put the spotlight on Bobby Jean McKinnon. You can come up and ask a question. There we go.
We can't hear you, Bobby Jean. Do you want to type it to us? Is Adam Toy still with us? I hear he has a question.
Yeah, so maybe we'll go to Adam Toy and then we'll come back to Bobby Jean.
Go ahead.
Yeah, hi there. Yeah, thank you so much for taking my question. Just looking at the individuals that you have here, one area of advocacy or data that I'm wondering about is the economic data. I know that other countries have really good data in terms of hours lost, people who are on long-term disability. I'm wondering if this is going to be an area that the society is planning to branch out into in part of your advocacy efforts.
All right, maybe Dr. Prasad.
Yeah, I think that definitely is an impact. I personally have been monitoring a lot of the actuarial tables, like looking at excess deaths. But I think economic impacts, especially when you consider the sheer number of disabled working age people. The best data I've seen is coming out of the United States, but I think this is definitely a priority that we need to highlight. Especially, you know, we're seeing fairly anemic economic growth in Canada, and living standards are falling, and incomes are falling, especially with costs going up. So I think the economic impacts are a huge priority, and thank you for highlighting that as a focus for us.
Adam, you've probably seen all the news articles about staffing shortages. The ones that particularly pop to mind are BC ferries, I seem to see all the time, teachers and healthcare workers. And guess who's the most risk for long-term illness from COVID? It's those forward-facing people like teachers, like healthcare workers, like BC ferries. And you know, they have large organizations that can monitor this kind of data and share it. You know who's missing from those stats? Restaurant workers, grocery store workers, other service industry people who don't necessarily have the data monitoring. But I think we all know anecdotally that they are supremely impacted as well. That would probably be part of why we've had such huge immigration the last couple of years, is to fill some of those staffing gaps, including temporary foreign workers. I would postulate that unless we solve this problem, we're going to continue to have these kind of economic issues. And so it goes beyond just caring for people, which I think is my priority, but for others, people who have other priorities, you know, we need to fix this.
And I see that Dr. Hume also has something to add.
Just to add in terms of, you know, the economic impact, every day a healthcare worker, because they see themselves in me, contacts me to tell me that they're newly disabled or can't work or are working part-time. So I think it's a really important part of the conversation that we really want to see back, you know, prioritized. I can tell you without naming names that a number of the physicians I work with are working part-time or reduced hours because of long COVID. So when we hear about we don't have enough nurses, we don't have enough physicians, you know, we don't have enough, the labor shortage, at least in the US, about 15% of all unfilled jobs are thought to be due to long COVID, 15% of all unfilled positions globally in terms of the global labor market. So I think we need this needs to be addressed, you know, at all of the levels of prevention and treatment.
Absolutely. And I would add that amongst colleagues that have had to reduce hours, even if they don't personally have long COVID, often it's because they've suddenly found themselves in the primary caretaker role of a family member that has long COVID, which affects their ability to work as much as they used to. All right, so we have Eugene McKinnon's question now, which is, all right, so I'm based in New Brunswick. Can you please speak up to what you know of the long COVID situation here and or your experience trying to find out more about the situation here? And also, can you please tell me how good a job you think New Brunswick is doing in helping people with long COVID compared to other provinces and why?
Hard for us to speak to a specific region without, you know, doing the research first. I can tell you that the maritime provinces were the shining examples of how to manage COVID up until about the second year of the pandemic. And then they became as bad or worse as everybody else, as far as what I can tell. Kudos to your Chief Public Health Officer, who had to acknowledge that COVID was airborne in a interesting exit interview as she was leaving her job. I do think she's one of the few public health officers who's gone ahead and acknowledged that, but it was a bit late after the fact when you're leaving your job. StatsCan has some excellent data from, I think it was released in October or November of this year. I would refer to that as probably the best source of knowledge on long COVID across the country.
All right, thank you. And so there's a question that came in online. Are there plans for multimedia campaigns, radio, TV, social media, bus ads, just general, I guess, education campaigns?
Perhaps I can take that. Right now, the board is just a small group to deal with administrative stuff. but we will have a bigger group of advisors and members who will decide, what is the next campaign. And for sure, the people who suffer from COVID will be represented on that. So I think the first campaign is very much up for debate now, and but we would like if it could come up in the next months. Am I missing something in the question? I'm not sure.
No, I think you nailed it.
Okay, thank you.
All right, Nicole Ireland.
Hi, sorry, last one, I promise. Just Dr. Vipond, you had mentioned sort of filling in a gap where public health has sort of walked away a bit from COVID. When you talk about airborne acknowledgement, I'm wondering federally, has PHAC not acknowledged that COVID is airborne or not done so to your satisfaction? I just want to make sure we're clear on that.
Yeah, I can speak long on that if you'd like. So in November 2021, there was a series of tweets from Dr. Tam about COVID floating through the air like smoke. And that has been the language that has been used by PHAC throughout their public communications. They have not said the word airborne out loud. We can speculate as to why that is, but it may have something to do with the legal implications of acknowledging an airborne threat to workers. There is the term aerosol, I believe, that's on their website. I think it's also important to recognize that if you're going to acknowledge that COVID is airborne, it's probably worth having a campaign to explain that to Canadians. We've seen no bus advertisements. We've seen no TV ads. We've seen no dedicated webinar to take questions from the media as to the implications of this. And so, posting it on a website, a couple tweets, in my mind, isn't enough. So if you go into my hospital at this moment, and you go into a COVID positive patient's room, it will say contact droplet on the sign for cautions. And that's not good enough. So how do we fix that?
Thank you.
All right, perfect. So I think we'll go to one last question. Melanie had a follow-up question, which I think is a great question. So once you do have sufficient funding, what will be the first action, sensitization, advocacy campaign that the society will focus on? Will more information be added soon to the website? What type of information will be offered? So basically, once this is off the ground, what are the plans? What is step one?
I can quickly talk to this. I think we can look at some of them, and this is an active discussion we're having. We can look at some of the more successful and more active public health departments across the world. So I'm in admiration of California, where during waves they have, the test it, treat it, you can beat it campaign. Something similar like that. I think just getting the public more aware of what's out there and the need to check, especially if you have risk factors or you're elderly, the need to access antivirals. I think taking over some of the roles that public health has abandoned first, and then we can expand. We've received an enormous outpouring of offers to help since we launched this morning. So I think we're going to have a fairly strong team to help us get through a lot of these things.
Okay, peut-être Nancy pour répondre en français.
Oui, donc j'ajouterais que notre première campagne de sensibilisation va beaucoup, ça va être une décision commune avec énormément de collaborateurs. Pour le site web, évidemment qu'on veut ajouter beaucoup de choses et on a acheté le domaine en français. On va avoir un site qui va être un miroir en français. Et pour cela, on réinventera pas la roue, pardon. Ce qu'on va faire, c'est que on travaille déjà avec beaucoup d'organisations, beaucoup de groupes, et on va essayer de donner de l'information de qualité d'un endroit que tous les Canadiens peuvent aller et auquel ils pensent. Donc, ça va être un travail qu'on va colliger l'information. Donc, c'est ça que je voulais dire. Merci.
Merci. All right, last word, Dr. Vipond.
I think in a perfect world, volunteers would join us and do all the hard work and it would be perfect. But the reality is volunteers don't self-organize. They need leadership. They need, there needs to be a structure. And so for me, I think the most important thing is to create that structure that will allow the empowerment of those who want to continue working on this successfully. So until we actually, I mean, honestly, the whole purpose of this, if it was just going to be volunteer led, we could just continue with grassroots organizations. The whole purpose of this is to create a formal organization with real staff doing the hard work, which will include volunteer efforts.
Thank you so much. All right, so we'll end today's press conference here, but all of the members of the board of directors, as well as Dr. Jennifer Hume, are available for interviews. You can contact them directly if needed. Thank you so much for being here. Donc, merci d'avoir été parmi nous aujourd'hui. On va arrêter ici, mais vous pouvez contacter les membres du conseil d'administration ou Dr. Hume au besoin pour en parler plus en forme d'entrevue au besoin. Thank you, everybody.
Merci, Lisa.
Thank you.